Good afternoon and welcome to our discussion panel. My name is Steve Ford and I'm editor of Nursing Times. We're going to be talking about the next steps to innovate patient flow and improve capacity in the system. So we're looking at themes such as transferable lessons and place-based approaches to improvement, using data and technology to release more time to care, and tackling readmissions. I'm delighted to welcome my three speakers who represent each part of the patient journey, namely primary care, hospital care, and social care. We have Julie Bolus, who is Non-Executive Director at the National Association of Primary Care. We have Tash Kelly, who is Nurse Representative for the Society for Acute Medicine. And we have Simon Williams, who is Director of Adult Social Care at the Local Government Association. So, each of our speakers is now going to talk for around 5 minutes on their area, and then we'll have 10 minutes for a bit of discussion before we open it up and take questions from you, our live audience. So first up is going to be Julie.
Hi, thank you so much, Steve. That's a lovely welcome, and I'm really pleased to be here. Sorry we're not here in person. I guess it might be important just to define primary care for a moment, just because I think there are some sectors, and particularly of nursing, that often feel left out when we talk primary care because people think general practice. And although general practice is a really important part of primary care, there's also the community services that are running significant services across our country, care home sector, which is again a first contact care. The 111 services that I know have been under significant pressure during the COVID crisis, and those people working in urgent care centres. So when I talk about my area, that's, I guess, what I'm going to try and cover. So, and I think this idea of what the current challenges are in primary care, there's a huge amount of activity that's had to be transferred into phone-based care and non-contact care for a while. And we're really seeing a ramping up of contact care now. However, the primary care system has been using phones and emails and video calls for some time now. And I think that it is a challenge for patients. And I think we need to remember for some patients this is great and for others it's not as good. So we need to just remember that the idea of how we've had to change the way we face our patients has changed during COVID. And it's very likely that that will continue to change. I expect that some people will go back to face-to-face contact because they will need to do that, but many people may find the online experience a good experience for both the patient and the professional. I think it's important to keep those two things there. I think the issue at the moment in the general primary care, I was speaking to a colleague who's a chief nurse for an urgent care company, and they've seen a 700% increase in phone contacts in this August from last August. That's a huge activity increase for those people on the front line. And so that idea of how we are holding back the hospital admissions is one important part of this, but really the demand in primary care is increasing as well. So we need to not only think about the pathway through to secondary care, but how the pathway into primary care is also increasing. So we're seeing an increase in number of people who are demanding services and needing services. So we perhaps need to think very differently about how we look at prevention in the future. And I'm going to pick up a little bit about population health. You would expect that from me from the National Association of Primary Care, but I will pick that up in a moment if that's okay. So in terms of challenges, we've got this increased activity, increased need and increased demand. And I think those things are going to be really important for us to think about when we manage our future state for the service offer that general practice and primary care in its widest sense can offer. I think the idea that COVID has gone is not in anybody's psyche at the moment. And so the increasing need for services to be prepared for a second wave of the virus or a longer wave of the virus is important, and that's changing the way that services can be managed. So if you're looking at screening services, for example, many of those are face-to-face, some are not, but many of those are face-to-face cytology screening, some of the cancer screening programs, etc. And they're not able to be managed unless we have a face-to-face offer. So we've got to manage the risk for patients, and that's certainly a challenge that's in primary care at the moment, that restarting of those services. chronic disease management, we're seeing a change in that. And so what we've started to see is some of those being done online, and people who might be able to dial in with symptoms or their readings from their blood pressure, etc. But many still require a face-to-face appointment. So we've got to get back and work out differently how we're going to manage that. And we're seeing some really interesting work in group consultation, which again, we can pick up when we do the Q&A if that would be useful. So some good evidence around that at the moment. Also, general practice is changing, and I use general practice specifically here because there's a new direct enhanced service, which means that general practice is within a primary care network now. And that contract landed just before COVID, so all the innovation that might have come from that, some of it's gone ahead, but some's not managed to be put in place. And we're seeing new ways of working across the primary care sector, which I think will be useful for the future. In terms of I know I'm on my last few seconds, but I think we just need to remember where the nurse's voice might be in this innovation for primary care. Many of those services through screening and through chronic disease management are led and managed through a nursing voice, but we're hearing on the grapevine that nurses are not using that voice or not able to use that voice. So I'm hoping today we'll have some great examples of how nurses can use their voice to innovate across the pathway. Thank you.
Great, thank you very much, Julie. That was fantastic. So next we have Tash. Welcome.
Hi, so my name is Tash Kelly. I am the nurse representative for the Society of Acute Medicine. I currently work in the newly formed University Hospitals Dorset, and the Royal Bournemouth site. So what I wanted to talk today about was, where we had come from with the patient flow pressures before the pandemic, going through the pandemic, and then what works and what hasn't been so successful, what has worked and what hasn't been. So the pressures before the pandemic, we had seen quite a surge over the last year in the amount of admissions that we've been getting through the front door. So I know that there had been a massive percentage increase in 2019 through the winter over the previous years. One of the main focuses for NHS England was to get same-day emergency services to take a lot of the pressure off the front door, but we know that it was 45% of same-day emergency care units had functioning impaired by hospitals using those areas as an overflow for patient admissions. So that really kind of impacted on the front door services that was able to be delivered. If the services are focused and used properly, actually we can, if they use a 5% increase of the amount of patients going through those doors, could see up to 14,000 overnight admissions being avoided, which would actually take some of the pressure off of the admissions downstream. The other issues we do have is obviously throughout the pandemic, we are now having to have COVID secure beds. Therefore, the amount of beds that we have got in the trust, in all trusts, have reduced because you need to keep social distancing observed throughout the hospital bed-based areas. So, and the other issue is obviously from the social point of view. So we're finding from acute care medicine to try and move our patients to downstream wards is becoming a lot tougher because of how this, getting people out from those areas. The other thing, the number of patients seeking urgent care has been low, what we would expect for this time of year because of the pandemic. We are concerned that there are a lot more people who are at home who are delaying coming to hospital and seeking same-day emergency care. So in actual fact are now coming, due to that delay, are going to be sicker when they do arrive at hospital. The access to diagnostics is also a huge issue for the same-day emergency care because, there is a massive delay across all trusts who are seeing that, because of the social distancing and the way in which we have to use diagnostics means there's a reduced service. Therefore, that hugely impacts the way in which we can get people through the hospital doors. The other issue we have faced is that we have had across the country 30% of the staffing that we've had have been redeployed to other areas, and then the staff that we have come back from, you know, that have been redeployed into our areas to support that are now being pulled back so that those services can resume as normal. But the pandemic is seeing an uptake, an upsurge. So now we're kind of, the staffing levels is also massively impacting how we're going to cope. Those services are going to cope. So what has worked really well is that actually the, access to services and the access to really urgently needed services has actually been unblocked. There's been a huge amount of work going on behind the scenes so that actually the patients that we do have are getting what they need when you know, when they need it from an inpatient point of view. But from those from the same day emergency care services, actually they have been, that's been more of a struggle, because you've had patients who would usually wait up to a week and wait up to 6 weeks for those kind of things to happen. So our concern for going forward is the winter pressures and on top of the pandemic, because you know, we're going to see our usual winter pressures. We don't feel that the admissions are going to be any less. You've got the concerns about the reduced bed base across any area, and then the patients who are coming in are needing to be in hospital for longer because they have waited so long in the community. So it is going to be it's almost like a perfect storm for the winter. So this is where all of our focus is going to have to be, to, if we can have better focus on same day emergency care, I think actually we can really unblock some of that pressure. But and the focus needs to move away from the emergency department and come towards the acute medicine, where all of these services lie. And that's our position. I feel that, you know, we need to come away from the emergency department and focus on the inpatients and the downstream flow. Thank you.
Brilliant. Thank you very much, Tash. That's really interesting insight there. And last but not least, can I welcome Simon to speak, please?
Hello, thanks very much for the chance to contribute to this. Those of you who've never heard of the Local Government Association, essentially in a nutshell, we're the national voice of local government, about 320 local authorities. But the particular role I have is around improvement within adult social care. And we do that in two main ways, really. Some of the time we produce materials and publish things. And in this particular area, a couple of examples would be the high impact change model for transfers of care that some of you may have come across. Or about 4 years ago, we published a study with Newton Europe on how better transfers of care can lead to better use of resources. And another way in which we support the sector, particularly councils, but with their partners, is in a more kind of bespoke way. So we engage with local systems, with health partners, with social care providers, to really kind of listen to the problems that people are facing. And we kind of particularly do that in what we call a peer review way, so that the support we offer comes from people who walk in your shoes and face the same challenges. And we feel that's kind of really important. And over recent years, we've seen a bit of success in this area. We've reduced delayed transfers of care significantly over 2 years, from 2017 to 19. And with sort of different models, enabled a lot more people to start going home directly from hospital. We can believe strongly in a model around discharge to assess and what we call home first. And we were saying that for some years before this pandemic. In fact, some councils go so far as to say their policy is that no one should ever go into a care home for the first time when they've been in an acute hospital, because an acute hospital just isn't a great place to find out people's kind of potential and capability to live a normal life on discharge. So we've kind of gone, and the other sort of thing we went into the pandemic with was the kind of how difficult the social care market was finding to kind of meet people's needs. So the biggest single reason why people were staying in hospital for social care reasons was about lack of capacity in home care. And that's not because home care was sitting around sort of not doing stuff, it's just the challenges the sector has faced with recruiting and retaining a workforce, and just kind of making a go of this as a business in some cases. And so as we kind of entered the pandemic, I would say we've really focused on two main areas. The first has been working with the provider sector on their resilience and viability. We've worked with them to really gain a deep understanding of the cost pressures and other pressures they face, and then make the case to central government where we've needed for support, or kind of worked with councils to give advice on how to work with providers to kind of mitigate that, and have done some work on workforce recruitment and retention. The second main thing we've done is work particularly with the NHS on discharge. So we kind of worked on both lots of discharge guidance. We feel we'd like to see some better data to really understand how well that's going, and that's something we'd all like to see. But it's probably fair to say our general view is where there were already good relationships between social care and NHS partners, that kind of continued, and they made a good fist of the guidance. And where those relationships weren't so good, it could be more challenging. But probably the other thing that's really come front of centre here is, even if those relationships have been good, sometimes social care providers have not always felt to be around the table as much as they could have done. And actually we've really, where we've really seen good progress is where they've really been brought in and kind of worked with to find solutions. Probably the third area I would just mention would be work on reablement. We feel that the biggest single thing that's going to probably help all of us through the winter, in my view, especially with the challenges facing the social care sector, is if we can together give everyone, as they leave hospital, the chance to make as good a recovery as they possibly can in whatever setting they go to. And there's really good evidence that where that's done successfully, it leads to reduced demand for long-term care, reduced readmissions. And we feel we're doing some kind of quite bespoke work at the moment to really help some local systems right-size reablement and get it to work as well as possible. We know we're going into a really tough winter. We're under no illusions about that. So the work that I've described will continue, but we also know we are going to be particularly facing the challenges of keeping infection out of social care settings for all the reasons that we would know. So we need to do all the things that I've been talking about while also bearing down on infection levels. And we know we can't possibly do that unless we're working incredibly closely with our NHS colleagues, both nationally and locally. So thanks very much for the chance to make this contribution, and I look forward to some questions.
Fantastic, thank you, Simon. So, as I said at the start, we now have a little time for discussion. So I'll come to each of my speakers in turn again. I just had a couple of questions just based on what they've been saying. So Julie, would it be right to say in terms of primary care, we're kind of almost looking at more ways of access for patients now? So although we're going to have, people obviously talking excitedly about technology and things like that, but we're still going to have the old ways of traditional ways. So in fact, we're going to have just a broader way of people accessing the system. Would that be right?
Yeah, I think so. I do think that there may well be opportunities for people to access services in a way that was in small pockets of the country before, but might have now been more widespread through the COVID crisis. So things like the telephone, we think of innovation as something really wacky and sort of really hard to use, but actually the phone in itself is an innovation for appointments in some cases. So how, and certainly our colleagues in acute care, and I know Tash will probably pick this up, just picking up the phone and dealing with things is a really quick way of managing stuff. So I think we're seeing that Group consultations, I think we've started to see some work on that, and I'm really pleased to see how those are going, particularly for long-term conditions, not necessarily for acute care, but certainly for the longer-term care, as well as an online offer. The other interesting thing, and I'll pick it up in terms of best practice, but this drive-through service, which we're seeing quite a lot of, we've certainly had to see it for the flu jabs this year. That idea that you don't have to traditionally come into a service, but you could do things in a very different way, and in partnership with others, I think is going to be another way to really think about that. But we've got some great examples of that, particularly if you look on the NAPC website, for those people who want to have a bit of a check afterwards, there's some really great case studies around things that people are doing. So yeah, wider, but it's got to be patient focused, and I know we all know that. We're sort of sat here in a Nursing Times conference, aren't we? But just that idea of the person and very person centred is really important. The offer needs to meet that person's needs.
Great, thank you very much. So Tash, moving on to you, a lot of what you said I think will really chime with delegates and people who are watching. So essentially, we're looking at a bigger problem on the way due to obviously we had existing staffing pressures, and then you put on the fact that people have been redeployed and they're now coming back. Yeah. And of course, as you pointed out, people may be coming to you and the sector basically who are sicker because they've delayed because of COVID. I'm assuming that's right. And if so, what on earth do we do about that? Big question, obviously.
Well, yeah, that's a very big question.
Like this. So if I was well, I don't know. If I did have those magic bullets, what would you like, basically?
Actually, I would really like you know, for to have much more medical staff at the front door, because actually they are the people who are making these people better access, you know, and a lot more critical care outreach support as in that case. But actually the people are, when they're sicker, it's those people with the expertise. So the acute medicine team that we've spent a lot of time with developing those skills, bringing those skills, particularly our nursing staff, those skills that have you know, bringing them up. If we're bringing people from out of area, it is quite difficult to get those skills that we innately have through those people who choose to work in acute medicine. So it is being looking at, you know, getting some programs in which our practice educators have been helping with up and down the country, you know, in order to get those competencies built up for those staff, because obviously focusing on the skills that, you know, that people coming from other areas bringing actually is really helpful for those patients. So it's kind of looking at different ways and innovative ways of getting those skills up to date. I know that there are online packages for people who choose to come to work to the area, who are sitting at home and going through those things in order to bring those skills up. So it is that skilled nursing care at the front door that is really key, and helping and getting those competencies, those standards go is vital.
Great, thank you very much. And Simon, obviously you covered quite a lot of ground in your talk. Just for people to really think about it, what sort of shape is the social care market in at the moment? You know, is it being supported?
I think everyone would agree it's not in great shape, because it went into the pandemic, as I say, already facing challenges around recruiting and retaining a workforce. And on top of that, in the pandemic, it's faced a whole lot of challenges around increased costs, around PPE, kind of greater staffing, absence. And it's also faced a challenge about loss of revenue, particularly in care homes, because people understandably aren't wanting to go into care homes. So we would say, and I think the providers themselves would say, it's really challenging. how supported have they been? I think we think most local authorities have tried to give support as best they could, by doing things like kind of paying up front for care, helping meet with costs. And more recently, central government's come in with some increased support through the Infection Control Fund, which has been welcome, but providers would say isn't necessarily enough, because that's very much about paying the costs of sort of very much ensuring infection doesn't take a hold in social care setting. So as we go through the winter, I think the continued ongoing challenges they'll face will be about the income loss, particularly, and about having to do everything they can to keep infection levels down, while also kind of hanging on to their workforce and remaining commercially viable.
Great, thank you very much, Simon. So just to finish off this section, I just wanted to touch finally on one bit that Julie made again at the beginning, which was about the nursing voice, because again, I think that will chime with a lot of people. I suppose that the question is it's vital, and we at Nursing Times know that, but how do we increase it?
I think it's interesting, isn't it? I was looking recently, so I think a publication came out yesterday from GP, I think it was the GP magazine, which in effect had galvanised the voice of general practitioners through its roots within the communities, to talk about this idea of morale within general practice and this idea of what is needed as a lobbying element to their work with government, for example, and particularly around NHS England. Actually, I think it's a particularly difficult read in terms of how the general practice are feeling about perhaps how they perceive NHS England is supporting them. And I wouldn't want to comment too much on what the actual reality of that is. But when I think about nursing, particularly first contact nursing, I do appreciate we're in a different arena here today, so it's the broad spectrum of the patients. We don't really have a single place that you can gather that nursing voice. And I think when National Association of Primary Care has been trying to help is because we're a membership organisation where you're from the broad spectrum of primary care, not just general practice. Can we land something there? But it isn't easy because we're disparate, we're difficult to get hold of. So I think it would be really helpful if we could really, through your publication, Steve, and others, that really work on what is our nursing voice and how will we best use it. So let's really do that. I think it's interesting, I think the Department of Social Care are looking at the appointment of a chief nurse for social care nursing. Although it's interesting, I don't know Simon's views on that would be really quite interesting, but I think the care staff that we have predominantly around therapy is also lacking in terms of a single voice, and particularly in the sectors that both perhaps Simon and myself cover in terms of the talk today. Those therapy staffs and those non-registered but talented individuals also need a voice. But I think today's Nursing's Day, so let's think about that nursing voice in a better, more innovative way. I don't know whether it's just useful in terms of the workforce generally, and I'll keep my views, I guess, as broad as I can. But if we don't treat people well and we're not kind to them and we don't allow them to be the very best version of themselves, so we play to their strengths, not their weaknesses, we're in a real bit of danger here, aren't we? So if we see people throwing hot potatoes at us, telling us that we're not working hard, and if we're not smart, and if we don't know how to use the technology, etc., it's really unhelpful. So I think if we can do anything through today, it's really ask people to play to strengths, not weaknesses. Be kind. The best we get out of our workforce is when they are feeling cared for. And if we don't care for them in our roles, then I really don't know where they're going to get that. So we need to remember that, I think. I don't know if that answered the question, Steve, so I'll just check that with you.
Absolutely, Julie.
Can I just also say I absolutely agree from a resilience point of view as well. If the focus to staff well-being, the shift into that, particularly through the pandemic, I know in our trust locally, has been amazing actually. And because the staff feel cared for, they have been incredible. They've been amazing. Their resilience through this time has been fantastic. So I know that this absolutely works.
We haven't seen that across all sectors, Steve, and I think some people have had a really tough time. So I know Simon's probably got a comment around that.
Yeah, I mean, so I would welcome more focus on nursing in social care settings. It was in the whole Return to Nursing initiative through the pandemic, which is a great initiative. We got very few people coming back into nursing home settings of care through that. And we need to kind of get a deeper understanding of why that is and what are the unique challenges of kind of working as a qualified nurse in social care settings. And I would absolutely welcome a focus on that. I completely agree with the comments that are made more generally about workforce, and certainly one of the key issues for social care is about equality of esteem for the social care workforce, which has been a huge issue for many years. It was nice, wasn't it, when people started clapping for social carers alongside the NHS, but we need to now kind of turn that into something where our social care workforce, who do immensely difficult jobs, actually kind of feel that they are getting, as I say, greater esteem, and that's something that's going to last now for a few years.
Yeah, I completely agree with absolutely everything that everyone says there. I think it's all absolutely vital, and I think that's a really nice place to finish on this particular section. You know, the well-being of staff across all the sectors, you know, should be absolutely paramount right now and always, in fact. So as I said, that's the end of this particular part of the discussion. We now turn to the live bit of Q&A. So please get your questions coming in if you haven't already, and we will try and answer them for you. Thank you very much.